I ran through this talk again this morning because I'm basically a neurotic at heart and realized that it gets incrementally more and more difficult to put a 3D 4D session into half an hour as the technology and the permutations of this increase. So I've tried my best to touch on a lot of the really salient things just to give you a feel for what's out there and what exists. Apologies if it ends up feeling a little bit like a tornado. But that being said, I'm happy to go over anything with anybody at any point, and I have a hands-on session, I think this afternoon on 3D, 4D. I'm happy to take requests if there are any. All right, so I have the same disclosures today as I did yesterday. Conceptually, I always find that I'm stuck at square one with explaining the idea of what a 3D, 4D ultrasound is to people. And really, it's kind of like thinking of a series of 2D or super thin slice B-mode images that are taken in succession. I'm old enough to remember, and hopefully some of you are, where we had those little books that you could flip through, which were all discrete pages, but as you fanned through them, it appeared to look like a movie. That's really the best description of what a 3D data set is that I can give you. And once you acquire this data set, which is technically conical in its shape, and we'll go over why, you can just walk through it by serially going through those images. You can rotate it, you can slice and dice it. Honestly, as the permutations within render and multiple other things change, the sky is almost the limit. I also get a question frequently is, what's 4D? What's the fourth D? And the fourth D is time. So if you apply that to what we're all here for today, which is cardiac imaging, you can appreciate the value to adding motion, flow, contractility, valve motion, etc., to a data set. So the transducer differences you're probably all familiar with. A 2D transducer is sort of a typical curvilinear, sometimes linear transducer that really takes an infinitesimally thin 2D slice. And the red line you see is me kind of turning it on its side. What a 3 or 4D data set is a volume that a much larger transducer sweeps through and acquires as it is sweeping through that what we refer to as angle of acquisition. So this is kind of conceptually what we are obtaining, a conical data set that's defined by the angle of acquisition, and the other way, and the other plane would be the sector width, to determine what we're going to acquire in our volume. The final permutation to this is electronic matrix volume imaging, which is a further advance to the 3D, 4D transducer. And because of certain things within this probe that probably exceed my ability to review them, it images at ultra high volume rates. You can do a cardiac sweep in 3 seconds as opposed to 12.5, which improves a lot of things, including radically reducing your motion artifact when the baby moves. And this is largely because you're not limited by the mechanical movement of the transducer. It's an electronic sweep, so you're not waiting for an actual motor within the transducer to sweep through a plane. The other improvement to this, and I have some good images to show you, is because of the matrix nature of it, 3D, 4D data sets in general are always going to have the best quality of image and what we refer to as the A plane, which is the plane you were watching at or looking at when you scanned. And everything else that you do to rotate that image drops off a little bit in quality. When you use the E4D technology, the resolution in the orthogonal planes is preserved to a far superior extent. So, things to improve or consider before you get an image. I can't help but really think it's an extension of everything Tracy just told you. It's really basic image optimization, but adding a little bit of what you also have to consider for the volume-based imaging. Number one is to get a good 2D image. So if you have a really lousy 2D image, there's nothing magic you're going to do to it with 3 and 4D. I've been surprised on occasion where I have kind of a really lousy 2D face image on maybe a really high BMI patient, and for reasons I can only amount to, a stroke of luck, I'm somehow able to pull a beautiful 3D face out of that. But generally speaking, pay attention to everything that Tracy has just told you for 2D image optimization. Decide what your region of interest is. Remember, when you activate a 3D, 4D sweep, you are deciding what to place in that conical shape or volume of acquisition. So if you're interested in the heart, keep your box around the heart. I would tell you that it's probably good to cheat that a little bit. So if you keep your box super tight and don't include some of the lung and chest wall on either side or some of the diaphragm beneath it, it tends to be so coned in and focused that you lose a little bit of perspective and ability to look at things from a distance. But, decide what your region of interest is and maintain your 3D, 4D box to include that region, but exclude stuff that's extraneous and not going to be helpful to you. Angle of acquisition, if you think back a couple slides, is what angle we want the transducer to sweep through when we are getting an image. So again, think about what you're interested in, and that angle of acquisition is going to change depending on what you want to image. To go to the completely opposite extreme, and this will only be really familiar to OB imagers, if you're doing a first trimester ultrasound and looking for an ectopic that you can't find and want to get a full volume of the pelvis from sidewall to sidewall, you might sweep through 105 degrees. But if you're looking at a heart, the best analogy I can give you is if you think, okay, I'm going to get 100 slices in what I'm sweeping through, you really want 80 of those to be in the heart. And the 80 of them are going to be in the heart if you start your sweep kind of above the 3-vessel view and arches and end it just below the diaphragm. If your sweep is so wide that you're going to include head and abdomen, maybe only 20 of your slices are going to end up in the money shot, which is the heart. So be mindful of what your angle is. A good rule of thumb for cardiac is gestational age plus 5 or 10 degrees. Quality of acquisition, quality is inversely proportional to time. So a high quality image is going to take longer. A low quality image will be very quick. So that's always the balance, right? If your fetus is really active, you might want to drop your quality just to get the acquisition, but your imaging is always going to be superior with higher quality. Primary plane to scan, again, is largely related to the non-electronic matrix technology. The resolution is best in the A plane, so if the pathology you're looking for is in the 4-chamber view, think about acquiring the 4-chamber view. That being said, the beauty of volume-based imaging is we can rotate, so always just be mindful of what it is you're trying to demonstrate. And then finally, 3D or 4D. Again, cardiac is going to bear largely into the benefits of 4D imaging. But brain will not. Brain doesn't move. So unless you're looking at vascularity in brain, there's not a lot of utility to using 4D. And by adding that extra D, what you do is really drop the quality and increase the time. So decide if motion is important to you before you activate a volume. So once the volume is acquired, typically your machines will be configured to give you a primary image called a multiplanar display, with the A plane being what you were looking at when you acquired the image. The B plane is 90 degrees to that, and the other little piece of cheat information you get in the B plane is this will tell you what your sweep angle was. So you can see here we went from above the 3-vessel view to just below the diaphragm with an angle of 35 degrees. And finally, the C plane, which is the coronal plane, which is where the image drops off in the greatest quality. You'll also notice that there's a reference dot on all of the images, and that is located in the exact same place in space on all of them. So you can see here the reference dot is in the LV, it is here, and it is here. And really this is your hub for how you rotate the image. The reference dot will be the point in space around which all the rotation occurs. Once you have your multiplanar display, you can start flipping between a lot of the modalities that we're going to talk about shortly. So with really one push of a button, you can go from this to TUI imaging to rendered imaging, and we're going to cover those shortly. The options become a little more complicated for 4D imaging because we're adding motion, and 3D static becomes 4D stick, or spatiotemporal image correlation. All of these modalities allow you to superimpose color flow Doppler, HD flow Doppler, B flow mode, etc. And then within the render paradigms, you can remove the grayscale, remove the color, remove everything but the remaining vascular map. So these all fall under render permutations, which are probably what people are most familiar with when they talk about 3D, 4D imaging. Not to discount some of really the not quite as sexy volume-based imaging. TUI imaging is really good when you're trying to figure out sectional anatomy. And what it is conceptually would be about the equivalent of a CT scan, but an ultrasound. You will depict the image as a series of slices that you can choose all of those planes, X, Y, or Z, which were, your initial orthogonal planes. You can adjust the slice thickness, you can rotate, and really by using the reference dot, you can try to, figure out, if I put the reference dot in the RV, do I see vessel X coming out of the same ventricle? So it helps you orient yourself in lots of directions. So here's just a simple tiled image. In this case, we've set the slice thickness 2 millimeters apart, where we've gone through a 4-chamber view, really just as a kind of a quick scout shot to give us a tremendous amount of anatomy. So you can see with one quick sweep, you're able to reproduce all of these structures and document this anatomy. If you're looking at a structure that is far thinner, you might want to really narrow your slice thickness. So the tightest I can keep it is 0.5 millimeter, but really because all I'm interested in this case is the money shot is the aorta, you're going to want the most slices in that structure of interest, and in this case we're going to highlight the coarctation. You can also see that this is a TUI that has power Doppler or HD flow superimposed. So this is one of the other ways we can tweak the modality. Volume rendering is, again, probably most familiar to people. And rendering is one of those words that you kind of intuitively understand what it means, but it's really hard to explain it to people. And I think the best way I can explain it is taking voxel-based data, which is volume data, and converting it into a viewable image with added depth. And within that are various algorithms that allow you to smooth texture, highlight bone, highlight soft tissue, etc. Unfortunately, that's well beyond what I can cover today, but I'm going to give you some examples of everything. Before you start rendering, you have to understand from which perspective you're looking at the volume. So to make this even simpler, even though we realize it's a conical-based volume, just imagine it's a cube, because the render box you're going to superimpose is a cube. So what you need to understand and really choose deliberately is from which side of this cube am I viewing the image? Because if I view it from, the left side of the chest, I'm going to see an aortic arch. If I view it from a bird's eye view, I might see a 4-chamber view. So you have to figure out which side you want to look at a volume before you can know how to render it. In this case, the green line is your cheat line, or basically your glass ceiling. So here you can see we are looking, basically up from the diaphragm towards the heart and towards the head. So the render direction in this glass body rendered image is looking from beneath the 4-chamber view up towards the outflow tracts. Again, just adjusting your render box. In this case, you see I've taken the green line and adjusted it to assume basically a bird's eye view into the 4-chamber view. Here we've adjusted it to be smaller and include what we wanted, which in this case was the AV valves. And you can see we are staring upwards into the AV valves from the apices of the ventricles, in which case on the left side you can see sort of the fish mouth bicuspid mitral valve and the tricuspid valve on the right side. And here's just an up close and personal. To look at these rendered images better, remember we're looking at a structure with depth. Depth is always accentuated, made better or worse, depending on how you use it, by where the light source is coming from. So in this case, we can see a little icon here that shows us the light source is coming a little bit from the left, but really directed at the valves. You can also backlight them to look better at valve coaptation and see things from the posterior side. And here, just to highlight the advantage of electronic technology, which is e-stick, you can see here we have our reference dot really centered on the aortic valve. Typically, the coronal plane or the C-plane is where you almost don't have diagnostic information on occasion in a non-matrix acquisition. But in this case, even with doing nothing to this image, I think you can appreciate in the C-plane, you can pretty easily pick up the bicuspid aortic valve. And here's the rendered view of that. Surface rendering, again, can be just surface rendering. So here we're looking at grayscale of a severe aortic stenosis with a kind of non-contractile EFE ventricle. And here's looking up into the LVOT where you're really not seeing any significant opening of the aortic valve. So glass body, I think, is my favorite render paradigm within cardiology because you get the benefit of both grayscale and color flow and vasculature. So the color flow highlights the vessels within the structure, but you're making the remainder of the structure semi-transparent so you can see where these things lie in space. And that's important when you're looking at, well, I'm not going to give you the advance notice, but you'll see shortly. So the location of the vasculature is seen within the structure, but the vessels are not obscured by the structure. So here's just a glass body rendering of ventricular inflow and outflow coming up into a 3-vessel tracheal view. So you're able to see where the filling is in the ventricles, the integrity of the ventricular septum, as well as where the vasculature lies relative to, this is probably the SVC or trachea. Here's an example that shows a really nice mid-muscular VSD. The fact that we've superimposed the color on grayscale means you can pick off exactly where the VSD is in space. And this might be tricky if we were just going to be using color alone. Looking at vasculature elsewhere in the abdomen, this is a case of a fetus who actually had a left lower lobe lung mass. And I'm sure all of you know at that point you really start to assess where the vasculature to a lung mass comes. Is it systemic or pulmonary? And in this case, this is a systemic vessel coming off the celiac trunk that pierces the diaphragm and feeds the mass. Now, what we're able to see with grayscale is really the proof that this vessel traverses the diaphragm. You wouldn't know where the diaphragm is without the addition of the glass body. Really, again, good depictions of things like aortic arches, where vessels lie relative to chest, relative to lungs, relative to diaphragm. So again, highlighting some of the beauty of rotation and using these images to your benefit. Here, this is probably familiar to you just after Alfred's talk, here's an axial chest view of an abnormality of a left ductus arteriosus right arch. So you've got the trachea in the middle and the U-shaped configuration of the PA left ductus right aortic arch. So if you're astute, you'll see that there's another vessel we have here shooting off towards the left side of the chest. So typically when we look at aberrant vessels off the aortic arch, if you've got a normal arch, you talk about an aberrant right subclavian artery. But when you have a right aortic arch, you talk about aberrant left subclavian arteries. So now, because of the resolution in the orthogonal planes, I can flip this and rotate it and maintain really, I think, exquisite resolution enough to show you the true pathology of an aberrant left subclavian artery. Here's the little netter image shot where it originates off sort of the descending aorta on a structure called Commerell's diverticulum. Going one step further, color or power Doppler means we take away all the grayscale. Really what you're left with is a 3 or 4D dimensional vascular model. Because you're using the Doppler principle, at least in color, you have the ability to interpret direction of flow. The one caveat I would tell you with this is the direction is correct for the orientation of the fetus when you acquired the image. So, red towards, blue away from. If you start rotating that image, for example, take a fetus who's supine and make it stand up, the color signal's not going to adjust, so you have to, in your mind, understand what it meant at the time that you acquired the image. So here's just an example. This is many years old at this point, but really two, forward and away from the transducer, parallel outflow tracks with a DTGA. See, here's the example of the VSD we just saw, and you can kind of scope out that it's mid-muscular by looking at just the vessel renderings, but not as good an idea of where it is in space without the glass body. Here's just a 3D static model of a really abnormally knotted umbilical cord. The two holes that you see right here basically represent where the fetal legs were. So this is a tight knotted cord around the fetal extremities due to amniotic bands. Inversion mode is, again, another render mode, really the concept being fluid becomes solid and solid becomes hypoechoic. So again, for those of you old enough to remember negatives when we talk about taking pictures, this is probably a good analogy. So it really is good to show the delineation of hypoechoic vasculature, because what you're doing is taking a vessel where, at least in 2D imaging, you don't have an echo, and create something solid out of it. So here's just, back of the heart in inversion mode with all of the vessels coming in. Inversion mode is also really good to look at integrity of ventricular septum, because you're able to see defects more clearly as something that definitely crosses as opposed to the absence of something. And finally, here's an inversion mode of a whole first trimester heart, where you can really see crossing of the outflow tracts, the aorta coming back towards the left in the 3-vessel view, and the head and neck vessels. So VCI-A imaging, I think, is probably one of my most favorites. And what this refers to is volume contrast imaging in the A plane. What does volume contrast imaging mean? Simplest term, it means giving something a slice thickness. So if we go back to the first slide or second slide where we talked about a volume that we're going to sweep through, now imagine that this is a super, super, super tiny volume, maybe 1 or 2 or 3 degrees. And now imagine that we're not going to call it an angle of acquisition, we're going to call it a slice thickness. And that's really what we've talked about as VCI-A imaging. So it's real-time rendering in a super thin slice thickness. And this is what the transducer is doing as it's acquiring a VCI-A. So it's rapidly oscillating back and forth within that predetermined slice thickness. The advantages, especially for cardiology, is enhancement of tissue borders, improved distinction between tissues that appear isoechoic in 2D imaging, improved contrast and resolution of structures that include a solid fluid interface, so vessel walls, ventricular septums, et cetera. And if you use the electronic matrix technology, real-time inversion mode, which again is helpful for things like vascular communications or VSDs. This also is an old picture, but this was my aha moment with VCI-A. So you can see up here, I had a really small slice thickness configured, and I was scanning a patient where the fetus happened to be apex up. And lo and behold, there's this black hole in the ventricular septum. Well, the addition of the contrast imaging gave you these really sharp borders to appreciate the VSD, instead of just looking at, maybe there's drop out there and I'm not sure what that is. Given that this fetus was chest up and the apex was almost directly at 12 o'clock, I rapidly turned the transducer 90 degrees to see that the VSD, which, us non-cardiologists always sort of believe that they're holes, but they're not always holes. Sometimes they're slices. So here's the VSD in VCI-A imaging from a different direction. Here's some side-by-side examples of really small slice thicknesses to show the delineation of the contrast, valve motion, myocardial movement, et cetera, superior to the 2D image. Now, you don't have to do these side by side. You can image VCI-A as just a single screen, but most of these are done as side-by-side imagings just to provide some contrast for you. Better assessment of ductal arch and vasculature, especially LPA and ductal branches. Here, Norm should love this one. This is how tissue contrast between two tissues that often appear isoechoic is improved with this. Norm talked yesterday about ratio of compacted to non-compacted myocardium, and I think you can see that this technology really enhances your ability to pick that up. Here again is a with your 2D eye VSD that you're going to pick up without the benefit of color flow by using this. Inversion mode, again, just quickly, is what we've gone over, but in real time. Good to assess ventricular septum, valve motion. Good to look at areas that are kind of particular kryptonite for you. So one of the things that always makes me crazy when I'm scanning people is that subaortic septum, that LVOT kind of conotruncal area. Make sure there's no override. If you take a short axis view of the heart and look at this area in particular, that actually corresponds to your subaortic septum, your LVOT. So the fact that we're looking at this with inversion mode really proves that there's no communication there between the aorta and the RV, or the RV outflow tract. And finally, inversion mode of a transposition. So really quickly, in the few minutes I have remaining, we're going to go through biplane imaging, which is one of the modalities that we now have for the last, I guess 3 or 4 years, that we did not have previously with the older 3D 4D systems. And what this is simultaneous imaging of 2 perpendicular planes in real time and with high resolution and high frame rate. And these are the two, the A and the B planes that you saw earlier on the multiplanar display. And this is really possible because of the nature of the electronic matrix technology and the beam agility. So again, because I'm a believer in cartoons, this is what real-time biplane imaging looks like. So the standard plane you're used to looking at is here, which is the A plane. The B plane is exactly 90 degrees to that and steerable. So here we're looking simultaneously at a 4-chamber view, but also reproducing our short axis view. Now imagine doing this with, next time I have a nice muscular VSD, I have to make a point of doing this so you can see it in both directions. You can use it sort of interchangeably on arches to reproduce 3-vessel view from longitudinal arches and vice versa. So, for example, if you're imaging a late 3rd trimester fetus, and you can pretty clearly always get a 3-vessel view, but you may not be able to get longitudinal arch views, you can use this technology to really flip you 90 degrees and reproduce. Here from a ductal arch, I've reproduced a 3-vessel view, but I could have easily gone back and done it exactly the opposite way. Here's looking at what appears to be an anteriorly transposed aorta coming out of the anterior right ventricle. You can see the head and neck branches prove that this is an aorta. And finally, looking at really the same case, if I just cut across the outflow tracts, you see the 2 parallel outflows that is diagnostic of TGA. Volume calculation quickly, there are a couple ways to do this on the machine, either using a solid or organ mass calculation or an automated mass for cystic spaces. Conceptually, this is something called a sono-AVC. So I took what clearly is a hydronephrotic kidney and decided I was going to tell the computer to fill that hydronephrotic collecting system with a solid mass. And this was really originally designed to give you a volume. So now I know that this kidney is 9.8 cc's in the center. But it's also a great way to model shape. So if you think of what you can do with cardiology that allows you to quickly model shape, this is a useful tool. So here's a case of mine from a few years back. If you look at the heart, so clearly it's not normal. It's a case of tricuspid atresia, basically with a single ventricle. But if you look at the atrial appendages, you can see that they're a little atypical looking, particularly on the left side. And this was a case of right atrial isomerism. What we did in this case was acquire a volume, but use the automated volume calculation to model the shape of the atrial appendages bilaterally. And you can see that they both look broad-based and triangular. In my world, that looks like a Labrador's ear. But these are bilateral right atrial appendages as modeled by a sono-AVC. You can use volume calculation also for things like, in this case, a large chorioangioma. When you superimpose it with GRACE or glass body imaging, it allows you to model the vascularity within it, potentially for intervention or coiling or RFA, in addition to looking at the size of the mass. And finally, just quickly in the couple minutes I have left, we're going to look at stick M-mode imaging. And this really allows you to, at some point later, either a minute later, a month later, or a year later, allow an M-mode line to be superimposed to a stick acquisition to achieve accurate chamber and valve measurements. Now, the one thing you need to understand with a stick acquisition is that it's a single gated beat. So this is the very same beat over and over again. So stick M-mode is not suitable for rhythm assessment because you're getting the same beat over and over, but it is valuable for things like fractional shortening or ventricular diameters. In this case, you can see I took a 4-chamber view, I rotated the B plane, created a fractional shortening MO line, and you can get those measurements off this stick. You can also do things like tricuspid annular plane systolic excursion by adding an M-mode line in an entirely different direction. And this is a new measurement that we're using, how do I go back, to look at right ventricular dysfunction. It's the degree to which the tricuspid annular plane moves during systole. You can use the M-mode line across a VSD, for example, to plot direction of flow. In this case, you can see it's predominantly in one direction, although technically bidirectional flow. And finally, with the electronic probe, there's the option of something called real-time 4D. So this is not a stick-gated beat. This is a real-time clip of the heart that you've obtained that we're able to visualize in multiple planes. So what happens when you do this in real time is you drop your frame rate a little bit, well, quite a bit, because you're asking the computer to process the image with high quality in multiple directions. But because it's a real-time image, you don't incur the issue of artifact from fetal motion during an acquisition. And here's just a 4D sweep. You can see going up from the diaphragm into the 3-vessel view, back down again, and we can see reproduce, in this case, the ductal arch just in real time without having to do anything more. This can also be done with color flow superimposed, so just to give you guys some ideas. Now, the real-time 4D is useful for rate and rhythm assessment because it's not a single gated beat. So in this case, you can look for regularity of ventricular contraction. So this is a regular rate. There's no evidence of ectopy. And if you arranged your M-mode line differently, you could even show AV conduction. So summary, just to go over some of the salient features of electronic matrix technology, you can see it's everything that I've discussed here. I know it's in your syllabus, so I won't bore you any further, but I really appreciate your time. Thank you.